Let me introduce our speakers, and we will do this. The first speaker in the series on the agenda there will come up and speak. Then we'll do the second speaker and so on, and then they'll go and rejoin the table. At the end of that, I'll bring them up to the full table, and we'll do questions and answers for you. So our first speaker today that I would like to introduce is Sandeep Patel. And Sandeep has become a very strong patient advocate and a very good friend. Sandeep serves at the Department of Health and Human Services for Secretary Azar. He's the Open Innovations Manager, and he will be speaking on several different things, including Kidney X. Next, we'll have Miss Jennifer Erickson. And Jennifer is an interesting person because she is a fellow veteran of being a political appointee, and she was so under President Obama on Obama's team in the White House Office of Science and Technology. She understands the intersection of science, research, and public policy. She's a veteran of Capitol Hill as well, and she has a very particular perspective on some of the issues that impact organ availability in the United States, and she has been a firm ally, and probably no better example exists in our world of it doesn't matter if you're Republican or Democrat. Those issues are not asked when you're in kidney failure. And Jennifer, the spirit that she has and the talent that she brings to this is very much like that. Let's get the problem solved. The labels are outside. And that's what we think is the ideal for moving forward. Sarah Froelich is the Vice President of Government Relations and Policy with Akebia Therapeutics. She's been very active with us and likewise on issues of regulation and payment. Chris Leibenguth, yes, who's a good friend and a Director of Federal Government Affairs and Alliance Development with Baxter Healthcare Corporation. And Chris has been very candid and approachable to us as a patient organization in highlighting the concerns that private sector has in making new innovations available to patients. In full disclosure, I lived for 3 years on a Baxter home dialysis device, which allowed me to keep working, keep my job, keep my house, and keep my career intact. And most of the people around me fairly happy because I was out and moving. So thank you for what you do. Next, we'll have Ms. Patricia D'Antonio, and she serves as the Vice President of Professional Affairs for the Gerontological Society of America. And Patricia also serves as a leader of the Patient Access to Pain Relief Coalition, which she will describe in detail, which has been in existence for about 4 years. She is a pharmacist, and as most of us as kidney patients know, your pharmacist is probably one of your best patient advocates because you walk in with a box of stuff and they're like, don't think so, who told you to take this, and et cetera. So we have a lot of interesting conversations running around on Capitol Hill. And our last speaker is Ms. Sarah Van Gertruden.
Very good.
Yes. See, prednisone, coffee, and Coca-Cola all at the same time. Hi, Trish. How are you? And she serves as the executive director with the Partnership to Improve Healthcare, or to improve patient care. But probably most importantly, she's a very trusted ally, an expert on a very timely issue of reauthorization. And we put reauthorization on this panel as well because this involves the Patient-Centered Outcomes Research Institute, or what many of you know as PCORI. And PCORI in particular has spent close to $70 million and funded 17 studies over the past 10 years in kidney disease research. And AAKP has been a proud partner of all PCORI-funded research projects, our patients, since the day it was started. And so the issue of reauthorization is important, not just to PCORI, the entity, and the hardworking folks who are there, but just as importantly, it's important to us as patients because you need the long-term thinking of research to inform innovation, many of the things that Sandeep and others will talk about. So without further ado, I'll go ahead and ask our friend Sandeep to come up.
Thank you, Paul. Thank you, Richard. Thank you, AAKP, for giving me the opportunity to tell you a little bit about what we're doing, or one of many things we're doing at HHS to improve the state of kidney care. So I know you all know this. I think I want you to know that I am starting to realize this. But the status quo of kidney care today is just unacceptable, no matter how you slice it. And one piece of that equation that's missing is the fact that the rate of development of new therapies, new diagnostics, new medical products to help patients all the way from early stage kidney disease to kidney failure is just embarrassingly low when you compare it to just any other area of healthcare. And Exhibit A is dialysis, where I could probably spend actually a whole day talking about the improvements from 1962 to today on dialysis. But the fundamental fact remains that it is the same therapy, and the experience of dialysis is the same as it was several decades ago. And it's just something that I think is unacceptable, and it's a time to think about what we can do differently in that space. So again, I know you all know this, so I'm going to skip right through, but if the state of care isn't bad enough, well, at least it's really expensive. Medicare spends about $34 billion a year to treat end-stage renal disease, which, just to put it in context, is the entire budget of the National Institutes of Health. So our research budget in biomedical science is the budget to pay for care and dialysis. About 7% of Medicare, and rising because of the pressures of hypertension, diabetes, and other risk factors. I'm going to dive into a little bit about sort of what's broken, or what I see that's broken, and try to transition, not to stay on the gloomy part too much, try to transition to how we're trying to address some of those areas through KidneyX. So one piece of evidence here is that this is the data on the right. You can see year by year numbers of venture capital investment in healthcare in the United States, it's going up. What you can see on the left is a breakdown of disease. What you don't see is kidney or renal. This is in biopharma, this is in medical devices. The sort of take-home point here is that investors and the industry does not categorize kidney disease or renal as something they're looking at, which I think is a problem. It doesn't necessarily capture what's out there in terms of investments, but it's certainly people are not looking for it, and I think that's a problem. And just taking a step back about the whole picture. So there's a bunch of issues. So one is that, as you sort of saw in the last two graphs, there's a dearth of capital. There's not enough investment money. There's not enough research money. We're not putting enough money into understanding kidney disease and developing therapies for it. And even if we did suddenly come up and win the lottery and had several $billion to invest, there isn't really enough out there right now that's investable either. There are some great things out there, but relatively speaking, we can do a lot better on that front. This is a complicated space. There's a lot of scientific gaps. There's a lot of amazing work being done right now at NIH through the Kidney Precision Medicine Project and many others to try to uncover new opportunities for developing drugs and other therapies. But it's an area that still has a lot of scientific gaps. And apologies to any nephrologists in the room or clinicians, but nephrology is a pretty unattractive space, right? When you go into medical school, most people don't think about nephrology as they're not thinking they want to get into nephrology, right? There's a perception issue of the level of importance and excitement in that field from a researcher, clinician perspective that I think has to change. There's no sense of urgency in this space. When there's an infectious disease threat, there's an entire infrastructure within the government and the private sector that just turns on, right, to respond to that. And we don't have that level of urgency for kidney care and a lot of other chronic conditions as well. And there's what I would call the good enough syndrome. So we invented dialysis, we have transplants. People kind of just say, good enough, we're good, we're paying for it. What else do we need to do? And I think we fall into that trap. I don't think there's another area of healthcare that I've seen where we've designed an entire infrastructure, payment, delivery, the way we train people around a therapy. And I think that's had the unintended consequence of just stifling innovation and creativity and what could be done better. And so I think the way to address this, I'd sort of break it down to three groups. One is financial, right? We need to fix the end-to-end kind of capital to take good ideas, invest in exciting, smart people, and all the way to commercialization, right? We need better flows of money throughout the process. And I think the only way to do that is to find ways to share risk between government, industry, and foundations. And this is one of the things we're trying to do with KidneyX that I'll show. There's the perception issue. Again, I think there's an opportunity to create an attractive environment for people who are unfamiliar with what can be done to improve the state of care for kidney disease. So myself, I don't have a family connection to kidney disease. My wife's distant family actually has a PKD, but that's not the reason why I'm in this space. The reason why I'm in this space is because, well, I talk to patients every day and I hear about the problems, and I feel like I have something meaningful to contribute. And I think that's the kind of that's the attitude we need to take to attract other people to say, hey, we need smart people from all walks of life on these sets of problems, right? And part of that is sort of expanding and creating a notion of what's possible instead of just focusing on what's wrong. And that's, again, one of the things we're trying to do with KidneyX. And the last is policy, right? And I'm a physicist by background, so I use a lot of physics metaphors, but there's too much friction in the process. We need to make that process smoother from, if you're an entrepreneur, if you're a patient, a clinician with a great idea, how do you take that to the next step, all the way into a product that can be given to other patients? And so that's on us to make that process, partly on us, to make that process smoother from a regulatory payment perspective, and we're looking at that. And lastly, we just need to demand innovation, right? We need to say, we as HHS have the convening power to say, we need something better for everybody, and so we're trying to do that as well. So KidneyX, so we're essentially doing two things, and hopefully leads to 3 and 4. So one is we are pulling money together from the public and private side, and we're offering money through prize competitions, each targeted at unmet patient needs, and trying to support, again, new talent, outside talent, people who have solved problems in other spaces as well as in the space already, and give them support and runway to get those products developed, whether they're therapies, diagnostics, whether they're just tools to help patients manage their experience better. There's a whole variety of opportunities there. And I'll focus on the patient piece because one of the principles we have is that we want to be patient-driven as to the extent possible. The second I've gone over, but we are a payer, we are a regulator, we're the largest funder of biomedical research in the world. We don't often talk to one another within our own shop, so there's a sort of fixing of our own house that has to happen. People need to talk to one another. We need to figure out from the experience of others, how do we make it smoother so we can get products onto markets faster. And hopefully if we do 1 and 2, the goal really is to de-risk commercialization. We want to make this a space where there's a natural flow of money, there's more shots on goal, there's an excitement, people understand what the problems are to be solved here and they want to contribute to them. And fourthly, along the way, we have to, again, create this sense of urgency. I think we have to get out of this good enough syndrome. And you all are doing amazing work to break that perception. And I think, I would ask you to continue that path because I think that's a really important piece of the whole puzzle. All right, so when we started this project, we sort of sat down and we wrote a bunch of principles of no matter how we were going to do this, we were going to try to adhere to these. And I won't go over all of them, but I want to hit 2 of them. So one is patient-driven. We don't want to be patient-centric. We want to be patient-driven. The problems we want to try to attack, we want them to be derived from patient needs, caregiver needs, derived on the ground. And we want to involve patients along the entire process. And I'll describe a little bit how we're doing that. And the second one is in the middle is catalytic. This is not a program that's ever going to be the focal point for everything, right? All breakthrough therapies in kidney disease are not going to run through KidneyX, and we know that. We just want to be catalytic. We want to be impactful enough that we can catalyze everyone else, bring enough attention to this space, whatever it takes, right? So we partner with the American Society of Nephrology, and I won't get into this, but we bring very different things to the table, and it's a great partnership. And this is sort of the cornerstone partnership, is what I would call it. But this is very much something that we want to do collaboratively with the community as much as possible. So the first prize out of the gate for KidneyX is what we call redesigned dialysis. So let me take a step back and just say that we base this off a piece of work that the Kidney Health Initiative did, which is a partnership between ASN and FDA to look at non-competitive sort of systematic issues in kidney care that the industry, government, advocacy, patient space could sort of come convene on together. And one of the things they did was produce this report called a Technology Roadmap for Alternatives to Dialysis, basically, renal replacement therapies. And it lays out basically 3 or 4 kind of types of therapies that they envision could be possible to develop if a certain number of scientific and technological and payment and other hurdles were addressed. So enhancing dialysis, creating portable wearable dialyzers, creating something that's an implantable device that could replace kidney function, and talking about regenerated kidneys. And again, going back to the patient choice, the idea here is that if we could realize one or more of these products, this provides greater choice for patients at the end of the day. And in many cases, superior options to what exists currently. And so we want to break this paradigm of there's transplant and dialysis and that's it, right? So this is a $2.6 million prize. We just finished the first phase of it. Actually, let me go back. So I mentioned patient-driven. So the report, the roadmap that KHI did, started with what are the patient quality of life items, the things that patients really care about, that whatever is developed, they have to be addressed, right? Things like obviously treatment choices, ability to travel, financial impact, medication burden, all of these things we embedded in our prize, as well as the report did, as mandatory things that have to be addressed. And we even required everyone that participated in the prize to address these in the design of whatever they were proposing. So $2.5 million prize. The first phase is what we called a design phase. We basically asked the world for ideas on paper on how they could contribute technologies, approaches that could realize those types of products. And the idea is that we wanted to start building a community and a pipeline of ideas, bring in ideas, things that worked in other spaces, into the development of these kinds of products. We had a summit last month. What is it, June now? Yes. I'm losing track of time. Where we announced the 15 winners. We had 165 submissions, which was just fantastic. Again, like I said, from all over the world, everybody from college students to medical school students, engineering students, to venture-backed companies, to publicly traded companies. There are a lot of folks who decided that they wanted to participate in this. And of the 165, these are sorry, I don't have a better graphic, but these are the winners that we invited to the summit to give lightning talks about how they were going to improve the state of kidney care through what they were doing. And just to give you sort of a flavor of what this is, it sort of broke down into 3 categories. So there's a bunch of people who proposed, better sensors for measuring infection, thrombosis, vascular access status, things that really matter on a day-to-day basis when you're on dialysis. Proposing those types of things. Where I think, even if we're talking about this can contribute to the current state of care, but it can also be embedded in these sort of futuristic devices as well. The second is these ways to improve dialysis. So again, there's a whole bunch of things, from somebody proposing better molecules to have more customized filtration of toxins. So we had a chemist from Temple who'd never heard of this application of his work apply and win. Which I think is a great story, because that's the kind of people we want to bring in. So there are a bunch of stuff on the improving dialysis piece, where again, I think there's multiple uses of this stuff, and depending on how that kind of shakes out. And we want, to the extent possible, to create collaborations within, and across these groups. And so we gave them an opportunity to actually talk to one another as much as possible. In fact, 2 of them, right after the summit, one of the folks flew out to meet the other about a week later after the summit to start collaborating, which I thought was great. And the third is what I would call sort of the re-engineering or engineering piece. So these are groups that are, some of them we knew about, some of them we didn't. These are guys that are working on developing the devices, right? There's a company, Miromatrix, that's developing, trying to regrow kidneys, essentially. There are groups out there developing implantable wearable dialyzers, and they came in. And I think what's interesting is folks like that often have gaps in what they're working on, and where they can benefit from the work that the other people are doing. And so again, that's the type of collaboration we're trying to create. The second phase is running right now. This is a prototyping phase. So by the end of the year, essentially, we're starting the submission. But we're asking folks to build a device that can be testable, that could start creeping into getting into animal and human trials. And so we're going to make awards of 3 awards up to $500,000 a piece. You do not have to participate in phase 1, participate in phase 2. So this is live, or it will be live soon. So please spread the word on this. We're trying to make sure this is available and known from, all over the world essentially. I won't get into this, but this is basically from the roadmap. These are the elements that we're looking for. These are the things that the kidneys do that we want to replicate. And one of the issues with dialysis is that it doesn't do all of these, right? And so a lot of the symptoms that folks in kidney failure feel are because dialysis does not address all the kidney functions. And so we want to think about devices that could do all of these and bring together component technologies that could create that functionality. So we're specifically looking for those things. So I'm focusing on the dialysis piece, and I would sort of classify it as building an artificial kidney. We're trying to build an artificial kidney, or we're trying to get others to build an artificial kidney. But I think the ideal world is, let's build the artificial kidney, but let's create a world of kidney care where we never have to use it. And so we're also going to focus through KidneyX on looking at how do we jumpstart development of drugs that can slow progression of kidney disease? How do we look at diagnosis early on? How can we look at other factors that can delay or prevent kidney failure in the first place? And so those are areas of focus that we're gonna look at in the future. But I'm gonna stop there. I'm gonna say one little bit about sort of HHS broadly. There's a lot of work. KidneyX has helped catalyze, along with other work, a large effort within the department and government across government to just change the state of kidney care, all the way from prevention to patient choice and modalities that currently exist to the availability of organs. And I unfortunately can't say a whole lot about it, but there's a lot of stuff coming out in the next few weeks. So please pay attention. Thank you.
Hello, everyone. I'm Jennifer Erickson, and I am so grateful to be here with you today. Thank you so much to Paul and Richard and Diana for everything you've done to bring this community together. And I will say at the outset that while I'm going to talk about data and transparency, and that might sound abstract, to me this is absolutely about patients. I've had a ringside seat to kidney failure, and that is what has motivated me to stay involved in this space since leaving the White House. So please know that I am very grateful to be here with you today. So we're going to talk about transparency, accountability, and acting in the patient interest. So as Paul mentioned, I worked in President Obama's Office of Science and Technology Policy, so I started exactly where Sandeep is now. How do we 3D print our way out of this? And I could not be more excited about everything that's happening with KidneyX and what people are doing to get a better future for people out of the labs into their quality of life. And so I'm a huge ally of all of that work. We had a summit at the White House. Some of you were there back in 2016. There were amazing commitments. Again, a lot around science and technology, around living donors, also important from people you all know at AST, ASTS, ASN. Sorry to dive into acronyms. Government colleagues at the Department of Defense, at HRSA. Foundations like the Laura and John Arnold Foundation, who I've stayed involved with since leaving the White House, Cystic Fibrosis Foundation, companies like Google and Facebook. It was really exciting. And a lot of that great work has continued. I will candidly tell you what I did not spend much time looking at then is what I want to talk to you about now, which is the single thing that I believe can help the most patients right away access transplant, if that's what's good for them. And that is making sure that the deceased donation system is operating in the patient's interest and as effectively as possible. Now, on the data, 95% of us support organ donation. I don't know about you, Paul, I have never seen that level of support for anything. 4th of July, probably low 90s, right? So the point is, this is something we as a country agree on. And so what is alarming and exciting, but is alarming to realize it's not working at the level we all might have thought, exciting to realize that that can absolutely mean more opportunities for transplant. And so that's what I want to talk to you about today, because allocation fights are about scarcity. So what I want to talk to you about is how we make sure that we are honoring all potential deceased donor wishes so that the other side of that, the patients who could access transplant, are able to do that as much as possible. Well, let's start with some numbers. How big could the potential be? Well, there have been multiple studies in recent years. Don't worry if you can't read the ant type. I'll just tell you some headlines. There's a deceased donor potential study that was published a few years ago that said we might only be currently capturing 1/5 of our current potential. The Washington Post, you may have seen, did a big investigative series that started in December and ran early into this year. They did their own analysis. They thought we could get 75,000 more organs per year for transplant. University of Pennsylvania and Bridgespan Group, they did an analysis of hospital ICD-9 codes, which we know vaguely we know actually specifically where people die and causes consistent with organ donation, and they found there could be 28,000 available organs. Now, I'm not here to litigate which of these numbers is right. All I'm saying is we all have an interest in making sure that the system is operating as effectively as possible. Now, I'm just going to dive into what that means for kidneys on one of these studies, the UPenn study. Again, don't worry if you can't read all the numbers, but you'll see the big bar is kidneys, right? Dark blue, that's deceased donor transplants. You get about 12,000 a year. The data set they had went through 2014. And so you see kidneys, livers, hearts, and lungs. The bright blue bar is what happened if the system were operating at maximum efficiency. 17,000 more kidneys. If you look at livers, more than doubling of liver transplants too. 1,500 hearts and lungs. Now, are we going to be able to recover every available organ? Of course not. But does this absolutely animate me to believe that we could do more? It does. So now let's talk about the front line of organ donation. So that is organ procurement organizations. Now, those are government contractors that have a contract for a monopoly area to operate and help coordinate organ donation. This is a map, this is from the National Academies, and it shows you sort of where they are around the country. There's 58 of them, and their job is incredibly important. The modern system of organ donation, back to what Paul said, it's bipartisan. The legislation that put the current system in place almost 40 years ago, it was introduced by then Senators Orrin Hatch and Al Gore. So they sort of codified this system, and I just want to point out a couple of things that we know. We know that performance varies a lot around the country. And we know that that performance cannot be explained just by demography. Okay? So what the other thing we know is in the almost 40 years the system has been in place, no government contractor has ever lost their contract. All right? So now let's talk about why. In one of the Washington Post stories, there was actually a quote from a longtime HHS, Department of Health and Human Services, official. You can read the full article, but the nutshell is that a key problem is performance measures. So CMS, the Centers for Medicare and Medicaid Services, they're part of HHS, right? And it's their responsibility to make sure these contracts are in place to certify or decertify these government contractors. Well, the data that they rely on is self-interpreted and self-reported. And so what we know from the Washington Post is that it's not rigorous enough to hold them accountable. So that's a problem, right? This is where data and transparency starts to become real. We don't just have to take this HHS official's word for it. Back in 2013, there were letters to the Regulatory Affairs Group, part of the Office of Management and Budget in the White House that looks at these things. One OPO wrote, the data that OPOs submit to CMS, again, that's the government, in connection with the outcome measures is self-reported and unaudited. The Association of Organ Procurement Associations said accuracy and consistency of data cannot be assured. Okay, so that was 6 years ago. So we know there's a problem. And don't worry, we're going to get to a fix on this, because if I hope to convince you of two things, it's that there's a huge and urgent opportunity and that it's totally fixable. Now, in a recent letter on the back of some of this reporting to the CMS administrator, Seema Verma, patient and provider groups, including AAKP, the American Society of Nephrology, the Renal Physicians Associations, and some of your colleagues and advocates in the liver community, they wrote, we ask that you change the metrics by which OPOs are evaluated to a new metric that is verifiable and not open to self-reported interpretation, so that this administration can become the first to enable meaningful OPO performance accountability, right? So again, might sound obscure metrics, very, very real. How many more patients could be able to access transplant? Well, you might have seen the New York Times really put a big exclamation point at the end of that sentiment last week. They did a big video package. I'd encourage you to look at it. If you haven't seen it yet, they profiled 3 patients, 2 of whom are waiting for kidneys, and someone who has worked in this space. And here's the pull quote. Every year, 28,000 organs, they're using that University of Pennsylvania data, don't make it to patients in need. Here's a quote. We used to report false numbers to make it appear we were doing better than we were. Now, false, let me pause on that. Again, you get to self-interpret and self-report. You get to do your own report card, right? So that's what the Times said. The reaction and leadership from this administration was swift, and for that I'm very grateful. Adam Bowler, who is a great champion of kidney care and kidney patients, he leads CMMI, so he works on innovation in the federal government. He wrote, Americans wait 3 to 5 years on average for a kidney transplant. In the meantime, thousands of people die waiting. The status quo is unacceptable, and we're committed to positive change. Seema Verma, the CMS administrator, she lifted it up too, as did the secretary himself, talking about the broader work they're doing at kidneys, and of course this is a key part of that, right? And just to underscore that they mean it, this came from the White House. Now, again, this might look dry, but this is absolutely about patients and transplant. They are saying, as part of the president's priorities, that they will soon propose a rule with changes to the standards used to evaluate OPOs, those are the government contractors who have a really important job on the front line of organ donation, and ensure proper data on available organs and transplants is collected. So you might have read that sentence and missed it, but let's be clear, that's about making sure more patients get transplants. So W. Edwards Deming, he received a national medal from President Reagan. He was an engineer and statistician. He said, in God we trust, all others bring data. And so what I hope, if I've been able to convince you there's a huge opportunity here that's urgent because we know 33 Americans die every day for lack of a transplant, then what I hope to convince you of now is we have everything we need to act. All right, hang with me through the circles. I don't have a physics degree like Sandeep does, but I'm going to explain a little bit about ways you could actually get a clear, objective picture of the data. It's total population. You could look at donors per total population. This is one of the international standards that's used. But we can even get finer cuts, right? You look at total deaths under 75 years old. Finer cut still, inpatient deaths under 75 years. And then this middle circle in, and you'll see the arrow has a yellow box around it, the Centers for Disease Control actually have data on inpatient deaths less than 75 years old from causes consistent with organ donation, right? So we have the data we need. Now, just so you know, for completion, there are smaller circles. You could look at state inpatient databases. You could look at individual medical record review. Let me be clear, that's not going to happen. That is a huge regulatory burden, and more importantly, it's not necessary. So let me put it a different way. The CDC, another part of the government, already has the data. The taxpayers already paid for it. We know there's an objective way that we can look at performance. And once the government has that objective way to look at performance, it can make sure that these organizations that are on the front line of organs donation are doing everything they can in patients' interest. And I want to give credit here. You can look this up. This is in the American Journal of Transplantation. It just came out this week. The authors are along the bottom, the chief of transplant at Vanderbilt, doctors from Emory and University of Pennsylvania and elsewhere. All the great ideas come from other people in this. So I want to make sure you know that a lot of people have been thinking about this. And management matters. Okay, so let me be clear about what performance means. I'll give you a couple of examples. In 2011, the government contractor in Nevada got new leadership. Within 3 years, its organ recovery went up by 67%. More recently, in 2016, in Connecticut, new leadership, organ recovery in 2 years went up by 95%. Now again, two sides of the same coin, right? One, that is incredibly exciting. There are so many more people who can get transplants. It is also I say this as someone who's been in government, to me, alarming that there can be that kind of variability and the government isn't able to go in and say, if a group or an individual isn't getting the job done, that someone else needs to be able to do that. Someone could do my job 17% better or worse, maybe 25% better or worse. But again, these numbers are really astounding. We've seen it even more recently in San Francisco. They got a new leader at the start of the year. We're only halfway through the year, and their organ recovery in San Francisco has dramatically improved. That's exciting, right? And that's why I want to hopefully end with this message that it's urgent, that this would help patients right away. We know this because it's happened, but we need to make sure that the government has all the tools that it needs, that the leaders at HHS have all the support they need to move forward. You know, a lot of people will say about data and statistics, oh, it's complicated, we need to study it further. Well, I'll tell you, when I was at the White House, I was told by people in the space that there were issues with data, with transparency, with accountability. And then I made some calls. And I was told, don't worry, there's a process. People are looking at it. Well, that was 4 years ago. I've shown you the letter that went to the White House 6 years ago. We can go back farther still. And so if I sound like this is urgent, if I sound impatient, it's because I am. Because we've known it's a problem for a while. We have ways to fix it. And everyone in this room has either experienced or seen the devastating effects of kidney and organ failure. So I want to bring it back to the patients because that's what AAKP does so well. That letter I said that they signed along with other groups and sent to the CMS administrator, it had, again, an exciting and heartbreaking point to make. As patients for whom access to transplant is literally a life and death issue, it is both encouraging to know that our cure already exists and devastating to understand that thousands of patients die each year as a result of ineffective regulations impeding access to it. So to Paul's point, you think regulation are things that happen in government? Do you think it affects patients? Absolutely. That's the point this is trying to make. And in closing, I just want to bring it back to some of the patients that were highlighted in the New York Times. As I said, there's 3 patients, Tanya Ingram, Angelo Reed, Maddie Bertrand, and I'm so grateful for their courage in telling their stories. Tanya, who's taken to Instagram, she says in the story she counts on social media more than the healthcare system to eventually deliver her a transplant. Angelo Reed, you see him in his car here? Because he's currently registered in 3 states and is looking at a 4th state in which he could register. This is life and death. And then Maddie Bertrand, 19 years old. She says, the system, it has to work for me. So that's what I want to leave you with. There's an exciting opportunity. It could be helping patients urgently. I am so grateful to this administration, to advocates like AAKP and others who are helping underscore the point that as much as we need to get to the future that Sandeep talked about, and I will be there every step of the way for that there's something we can do right now too. Thank you.
Thank you. So I'm Sarah Freilich. I work for Akebia, which is a Boston-based biotech company that's focused exclusively on developing new therapies to treat kidney disease. And I want to thank Paul and Diana and Richard for convening this forum today to talk about these important issues. What I want to spend a few minutes talking about is just the perspective of an innovator in this space and what are some of the barriers that make this really difficult. And it matters in terms of federal policies, both from a coverage and reimbursement perspective as well as other research-oriented federal policies. But we are so encouraged and so highly supportive of the Secretary's Kidney Health Initiative. I've been in the renal space now for over 15 years, and I never remember an HHS secretary ever talking about kidney disease, recognizing the importance of this from a public health crisis standpoint and from really being dedicated to try to improve care in this area. So we are very excited about where the Secretary wants to go with this, and particularly the depth of understanding that it's not just about dialysis, that it's important to address the high rate of the lack of diagnosis, and really focusing on trying to slow progression of the disease and investing in earlier treatments. And we're very excited about Kidney X, and Sandeep's done a fantastic job in terms of this initial prize grant awards that have been done in the last few months, and that holds a lot of promise, we think, to really accelerate the development of new drugs, devices, and digital health tools. But what we are concerned about is, despite all this effort, we get the message, we get the mission, we are 100% behind that. But if these inventions don't reach patients, then we won't have accomplished what we intend to do. And from the perspective of a pharmaceutical company involved in this, we are very concerned about some of the coverage and reimbursement issues that we're facing. And we sort of see this in two ways. One is the Medicare Part D program, where we think it's really important that CMS, meet the needs of kidney patients by ensuring coverage for drugs that are developed for this population. And then in the dialysis space, that's Medicare Part D. Part B covers the dialysis payment. And, we've had a prospective payment system now, a bundle payment, since 2011. And there are problems with that, and it needs to be modified now and modernized so that it can support the incorporation of new technologies and improve patient care. Sandeep mentioned Kidney Health Initiative. Paul's been very involved in this. I think you were just the co-chair of the last meeting. I think this goes back to 2012. AAKP is involved in this. We have a board member on KHI, but it's a very important ASN FDA public-private partnership because it's really focusing on what needs to be done here. We've acknowledged that there needs to be a more understanding of pathophysiology of the disease. What can we do to enhance the clinical trial infrastructure, to get more surrogate biomarkers validated? What can we do to have more unique clinical trial designs and bring the patient perspective into all this? But the fact that we have Kidney X now and KHI for a longer period of time just reflects the lack of innovation that historically we've found in this space. I think everyone's aware of the tremendous innovation that's occurred in oncology and cardiovascular disease. I think a great statistic here is between 2015 and 17, FDA approved 29 new drugs for cancer, 2 in chronic kidney disease. So I think it's clear that the investment into treatments in kidney disease is not commensurate with the huge toll that it takes on public health and the current mortality rates. But for those of us in this space, these early stage startups, it's really hard, as Sandeep said, to attract venture capital. And I think in large part, Wall Street understands what's involved in the ESRD payment system. They see this capitated payment system that's been very flat over the years, and they view this as a zero-sum game, that there's no room, if you will, for new innovation. And there have also been some negative cover decisions, which really undermine confidence in this space. And I'm going to use one of these as a case example this afternoon. So we've got an innovative drug developed for kidney patients. It was developed and it got FDA approval in 2014 as a phosphate binder to control serum phosphorus for dialysis patients. And we did additional clinical trials and got a second indication in 2017 to treat iron deficiency anemia in the non-dialysis population. It was great. All the Part D plans covered the product with no restrictions until recently when CMS withdrew coverage for the renal anemia indication without a lot of rationale as to why it did that. And Medicare really stands alone in that the overwhelming majority of payers, whether they're government or commercial payers, including state Medicaid programs, even managed Medicaid programs, TRICARE, the VA health program, et cetera, covers all the rest cover both indications. And I think it's important to note, too, that there aren't a lot of alternative therapies for CKD patients with anemia. OTC iron products don't work. Eventually, patients end up on IV iron, which may not be a big deal if you're a dialysis patient and you're in a dialysis facility 3 times a week. But if you don't have a port or any access system, then you have to figure out a way to get transportation's an issue. You have to figure out a way to get to a hospital or an infusion center, and there are risks associated with IV iron, primarily anaphylaxis and hypersensitivity. And the nephrologist that we have will also tell you that there's a lot of concern just because of the toxic nature of IV iron about potential damage and scarring to the patient vein system that's needed for hemodialysis if patients progress. Often patients don't get treated, and then if left untreated, they end up in the hospital. A hospitalist or an emergency room physician will see a very low hemoglobin. They end up with blood transfusions, and that reduces their ability to be matched for a transplant. So the consequences of these alternative treatments are significant. So we have been in conversation with CMS, and I know the nephrology community's weighed in, and certainly a lot of the patient organizations have as well. But we think it's really important to recognize that we believe this drug, for instance, is a new innovative product, does meet the definition of a Part D drug. There's no exclusion for anemia and chronic kidney disease. It is a unique chemically synthesized coordination complex that is remarkable, and that it has both a systemic and a local benefit. The local effect of this is to bind phosphorus, and the systemic effect is to raise hemoglobin. But we've gotten comments from some of the folks at CMS that it's a supplement, which we don't understand. Obviously, it's not a dietary supplement because dietary supplements can't make disease claims. And it's certainly not used for supplementation. I mean, it's been tested and has been FDA approved to treat the disease of anemia and chronic kidney disease. But we think this is a good example because it's really important for the folks that are making decisions about whether to cover products or not in this area to really understand kidney disease. As you all probably know, there are many reasons for anemia. There are many causes. In chronic kidney disease patients, it's not caused from a dietary or nutritional deficiency. It's caused from the inflammatory state that causes chronic kidney disease, where you've got hepcidin levels, this inflammatory marker protein, which rises, and that tells the body to shut down iron absorption and to stop the release of cellular stores. And so I think it's important for CMS officials to understand the cause of this comorbidity in this population, and the fact that it's really quite a serious complication, because not only do patients feel terrible from profound fatigue, but it's also associated with higher mortality, higher morbidity, and progression of disease. So I think this is a really good visual of sort of where this product fits into the space. I mean, we talked earlier about the $35 billion here that's spent on stage 5. That's for folks that have already progressed to dialysis, but you've got $79 billion in Medicare spending for stages 1 through 4, and that's really the population there where this product has benefit for use in treating anemia, because the whole idea here is we want to provide better management of patients before they progress to dialysis, and maybe we can prevent them from progressing at all. But as you go along the continuum of kidney care, or kidney disease, you see that there is, dysfunction of iron metabolism. Patients develop anemia. They get high serum phosphorus, and this product, with its dual mechanism, fits both of those conditions. So we have asked CMS to reconsider, again, with input from the renal community, and we think it's just a win-win in every respect. We think it's the right policy decision, that Part D doesn't exclude this, but it's about interpretation of what this product is. We think it's completely consistent with the Secretary's goal of incentivizing innovation, and more importantly, developing new therapies for earlier stage treatment. And we think it's very similar to vitamin D analogs. If you all remember the coverage problems that when the Part D program was put into effect, CMS initially said vitamin D analogs wouldn't be covered, and then CMS switched it's very similar, and that vitamin D that you get from sunlight exposure or even from diet can't be converted in a patient with chronic kidney disease because that has to be done in the kidney. So I think it's very comparable to anemia where elemental iron can't be absorbed by these patients because of the inflammatory response. So some product then has to be redesigned as a workaround for that problem. We also think it's the right clinical decision. Certainly the nephrology and kidney patient organizations have been aligned on sort of what this product is and what it's not, and the value and the continuum of care for these patients. And clearly most patients would prefer an oral drug than having to get infusions in hospitals or infusion centers. And we also think it makes complete sense for the Medicare program, and it's actually cheaper than IV iron. And there needs to be a recognition that CKD patients with anemia cost the system a lot more money than those without, and there's a delta there of about $30,000. So I'll stop here on this particular drug, but I think it's a great example where we are in this innovative space and have come up with an innovative product, and we think a coverage decision like this doesn't make sense and sending the wrong message certainly to industry. Another area I just wanted to focus on for a few minutes is sort of moving to the Part B ESRD bundle payment. And as I mentioned, this has been in existence since 2011. It was put into place to try to force efficiencies in the provision of dialysis, as well as to create the incentives that existed for overutilization of ESAs. And certainly this program has accomplished all that. But I think at this point in time, now almost 10 years later, the methodology and the system is pretty fragile. And even MedPAC, which has access to 100% of Medicare claims, even came out in its March report of this year that the margin for dialysis providers is now negative. And of course, they're looking at 2017 data. But and I don't know if you all can read this, but the margin now for dialysis providers is negative 1.1, and there's a huge lack of adequate payment in facilities with the lowest volume. So those margins are now at a negative 21.3%, even though urban facilities may have a positive margin. There is a 5.4% negative margin for rural facilities. This, to us, shows that payment is not adequate at this point. And we believe that the problem is going to continue and that the 2019 margin is going to be negative as well. And so I think this really requires another look at the methodology that was put in place to do updates on dialysis payment. And if you sort of go back to the sordid history of when this program was put into place, they sort of took the existing inputs, costs, labor, drugs, equipment, et cetera, from 2007, trended those forward. There's a productivity adjustment that's taken off the top, and what you end up then with is a completely stagnant system that has resulted in a very flat base rate in terms of payment for dialysis facilities. And again, these payments are supposed to cover all costs associated with dialysis treatment. So I think it's important to recognize that the system's really constrained, and for those of us that are involved in trying to develop new therapies, we don't see any room in the current system for drugs, devices, or even changes in medical practice to be reflected in payment. And I think this is a good visual. This is, if you look at the blue bar, that is the base rate. I think it's important to recognize that there are facility level adjustments and patient-specific adjustments, but the base rate has been essentially flat. It's even gone down. And not to be too simplistic here, but because there was a rebasing that captured some of the savings from the lower rate of ESA utilization. But the darker bar there is taking the original base rate set in 2011, and if it just was modified and adjusted for average medical inflation, that's where we would be today. So you look at this again in terms of innovation and wonder where the space is for innovation. So we've got a few ideas about what's important, and I really have to give credit to CMS and the last reg that it came out, the last rule that came out for calendar year 2019, in which CMS indicated that it's going to provide now a 2-year transitional payment for new drugs that are approved after January 1 of 2020. And this is really important because you see in the standard base rate payment, there's no room for anything new. This will allow dialysis providers to gain experience with new drugs. But CMS, unfortunately, is applying this TDAPA, what we call the TDAPA payment, to generics and biosimilars. I think it's safe to say that all of us in industry and the kidney community oppose this. We do not view generic drugs or biosimilars as innovation. We're also concerned about the payment rate. And every other aspect of Medicare, whether it's hospital, outpatient, or inpatient, the payment rate for new drugs is at the average selling price plus 6%, and CMS has set the payment rate at ASP plus 0, which is concerning because averages by definition infers that half the facilities will have acquisition costs that are higher than the payment rate. And we also have to factor in the fact that there is a federal sequestration which takes 2% off the top. So at the end of the day, this is not really covering the cost of new drugs. Another source of problem here is that it's contemplated that the separate payment would only last for 2 years. And because of the data lag, if CMS made a decision about how to make an adjustment for the base rate, they would only have like 6 to 9 months of claims data. And so we think it's really important because of the time that it takes for dialysis facilities to change the way they treat patients. They do pilots in certain clinics. Then it's very treatment protocol driven care. And in order for them to really assess the value of a new product and how it could be used to benefit their patients, this will take time and resources. And then last, we think the other deficiency in the proposed TDAPA is that they would make base rate adjustments only for drugs that fall outside the functional categories. And I don't know how familiar you are with this, but there are 11 functional categories that CMS has defined. One, for instance, is anemia management drugs. There's one for bone and mineral metabolism. But if you look at the functional categories, they're so broadly drawn that we view that they cover everything that could possibly be developed and that we know is being developed in terms of dialysis care. So I will stop here. And in conclusion, again, we are so excited about the direction of this administration, but we just really want to make sure that coverage and payment decisions, support the rhetoric for innovation and improving care. We think that, kidney patients are already in a situation where in their bundle payment system where they don't have equal access to innovation now, and that needs to be rectified by sort of modernizing the payment system. CMS needs to understand what diseases and comorbidities that kidney patients have and the need really to ensure that drugs, particularly for upstream treatment, are paid for, and that they seek some kind of balance for cost containment, which is what they did in 2011, and an ability to innovate, which is what the focus is now of this administration. So I think there is a lot of alignment in the renal community. I know innovation's been a big focus of most of the organizations in this space, and we look forward to working with all of you on these issues.
Thanks. Hello, everyone. My name is Chris Leibenguth, and I represent Baxter here in Washington, D.C. I don't have any slides. I did that on purpose. The reason I did it was because, oftentimes people like me get up and we walk through, here's my company and this is sort of all the sort of pieces and policies that we represent. And I'm definitely going to talk to you about that. But what I really want to do is give you a sense of what do people at Baxter, what are they thinking, what are they feeling right now? I mean, you guys have heard now, probably throughout the day, but definitely in this session, a lot of great speakers, Sandeep and Sarah, talking about what HHS is doing, what CMS is doing, and all these new things that are coming down the pike in terms of home dialysis, in terms of transplantation and innovation. And so it's kind of a momentous occasion. This is a big thing that's happening. And I think it was kind of maybe a time to take a step back and maybe give you guys an impression of what I see on a daily basis. When I go back to Baxter and I go to the headquarters and I walk around the halls and I talk to people, there's two words that really stand out in my mind that sort of represent how they feel these days. And one of them is anticipation, and the other one is determination. Right? And that kind of sort of falls in the two buckets that we're really focused on. On the anticipation side, earlier this year, the Secretary of HHS came out and publicly started talking about needing to grow home dialysis, needing to expand it, and needing to increase transplantation. And he talked about it in the context of the lack of it historically. He talked about the barriers that are sitting in front of it now, and he talked about in terms of what HHS is going to be doing going forward. And now we're all awaiting to see what those proposals look like, right? So when you go back to Baxter and you walk around and you talk to people, there is a tremendous amount of anticipation, But within that context, one of the things that we're doing as a company is we're kind of taking a step back and we're asking ourselves, what's our role in this? We're a manufacturer, we're a supplier. We have to be ready to go. If what they're going to do is they're going to increase home dialysis by large rates, we have to be there and we have to be ready to stand forward and move forward and make it a reality, right? And that's kind of a gut check time, for us. And we are a home dialysis company. It's something that we advocate for a long time. But now we're in a situation where there are things happening that can make the things we've always worked on a reality in a really big way, right? And I think that part of it actually is sort of. We spent a lot of time thinking about this in terms of what the government is going to do versus what the government's not going to do and where we fall into it. And I kind of hope as we go into this whole exercise that we look at in terms of what are we as industry stakeholders going to do to support what the government is putting in place. Because I don't know what they're going to do. We're going to see a proposal, I'm sure, sometime this summer, hopefully. And it's not going to be perfect, right? I'm assuming going to be audacious. There's going to be great goals in it. It's not going to be perfect, though. But no proposals are, right? No matter what program you're talking about, they get put in place, and there's a lot of work to do. And what I hope that we as community stakeholders, as industry stakeholders, start thinking about is what do we need to do to make sure they're successful? Because what all of this means at the end of the day is it has nothing to do with Baxter and it's got nothing to do with HHS. It has to do with patients, right? What they're doing is in the best interest of patients, giving them options, right? And so, that's what Baxter's saying internally, right? It's on the one side a dose of reality. We need to make sure that what they're saying and what their goals are achievable. But not in the sense that, they're not achievable, we're not going to do them. It's maybe they're not achievable, or maybe they are. But let's have that conversation. Let's have that conversation with the government. Let's have that conversation with stakeholders, and let's push ourselves to make sure that their audacious goals become realities. Because why else are we doing this? Why else are we here? Why am I doing it, right? I'm doing it because people in the government are taking a step forward. It's that kind of like on our side to take that step forward too and make sure it happens. And I think as the summer unfolds and we start sort of realizing what it is that we're dealing with in terms of what their proposals are to grow home and to increase transplantation, it's my hope, and it's going to be my focus of one of my focuses of attention is to make sure that community stakeholders work together on this, right? Because oftentimes in this space, there's like this, they go different ways, like a proposal comes out and they go this way. And I get that there's a tendency to do that because you look at things in a parochial way. But this is not the time to do that, right? This is the time to figure out how we as stakeholders can work together and overcome any sort of concerns we have with the proposal to ensure that proposal goes into effect and then is implemented properly, and that we see it through the end. And I don't know if it's going to do all the things that they say it's going to do, but this is the moment for us to act. And I'd even take another step and say, once this proposal goes into place, we're going to be in a position where we need to then think about all of the other things that have to happen to make it work, right? And to a certain degree, if HHS comes out and says, here's this great proposal, we're going to incentivize all this stuff, it's kind of on us then to figure out how to make it work, right? That's our jobs. And that's something that we take seriously and something that we're going to endeavor to do. And so when I say anticipation, that's what I mean, right? There's a lot of anticipation at Baxter, but they're taking it very seriously. And very excited, too. The other word that pops to mind when I walk around and talk to people there is determination. And this gets into a little bit of some of the other speakers' comments, especially Sandeep and around Kidney X. When the secretary gets up and talks about his focus on kidney care, he talks about increasing home dialysis, he talks about transplantation, he also talks about innovation, right? And we see the dedication that HHS has towards innovation. Look no further than Kidney X and the partnership with ASN. So where's Baxter fit into that piece? Because we're an innovator, right? And how do we fit into all of this? We are really focused, and really what I spend most of my time doing is looking at sort of the opposite end of where Sandeep is. So Sandeep is on thinking about how do we generate all of these ideas? How do we get more into the mix? What we're trying to figure out is how do we make sure that the proper incentives exist in the payment system so that once one of those great ideas starts moving through that clinical process, it doesn't get hamstrung when it's trying to go to commercialization, because that's what we face, right? As Sarah said, we have a bundled payment system, right? And the bundle was put in place for appropriate reasons, right? It's cost containment, but at the time there wasn't any great new innovations on the horizon on the device side. So that's just that dollar value is all you get, right? There's no additional dollars to pay for new stuff. Right, and that has a lot of impacts. It means that there's a lot less investment. Investors come, they look where they're going to invest. They don't invest in this space, right? And part of the reason is because that payment system is very calcified, done for I would say good reasons at the time. But now we're in a position where we need to start thinking more proactively about that payment system and adjust it so that it actually kind of conforms with all the things we're seeing. So if we're going to incentivize people to come up with new ideas through Kidney X, there has to be something that allows that idea to go through that process and then get on market and get into the hands of patients. And so now, reason why this is important to Baxter is that Baxter has a new product that we're trying to bring to market in the United States. It's a new dialyzer. It's called Theranova. It's on market in 39 countries. It's not. We're about to submit to FDA, so I don't want to go into too many details that wouldn't be appropriate. But it is something that we see as being groundbreaking, right? It's a de novo. There are very few de novos, if not any, in this space. And so Baxter's taking sort of the fact that we have this product, we want American patients to benefit from it, and we're taking that step forward to try to sort of force this issue with government stakeholders. And I'm pleased to say that the people we talk to, both on Capitol Hill and in the administration, are very receptive. We've had great conversations about this for almost 2 years. But what our proposal is to create what's called an add-on payment to the bundle. So you get the bundle, it's the $235. This would be a transitional add-on payment for new technology for a period of time. So when Sarah's talking about TDAPA, it's like TDAPA for devices. doesn't exist, right? So you have these mechanisms like TDAPA for devices or for drugs in the ESRD system. They exist in the outpatient system, drugs and devices. They exist in the inpatient system, drugs and devices. They do not exist for devices in ESRD, right? And that has the impact of stymieing innovation. And so what our proposal is to create that add-on payment for new medical products in the ESRD system. And this is one of those things where, that's sort of like I talk to people at Baxter and they say, Chris, you should go out there and advocate for this payment system or this change of the payment system. And I say, of course I'm going to do that. And it means a lot to me because I work for Baxter and I care about my company. I care about what they do. But it has extra meaning for me because creating this system, this new payment, wouldn't just benefit Baxter or benefit Theranova. It would benefit everyone, right? Because it would create a mechanism for anyone who's got a groundbreaking idea to bring it to bear and get it on the market. It does not exist now. And so that gives me just that much more emphasis to drive this forward and to get this thing in place in this year, if it's possible. So that's kind of the broad view of that. I do just want to take one quick moment and then I'll stop and say that so I've been doing this job for about a year, so I'm kind of new here. And on my first day or first couple of weeks or months in the job, I would walk into these meetings and stuff, and I talk to all these new people I was meeting, and I say, "Hi, I'm from Baxter. I've got this great idea. It's a pass-through payment." I got a lot of like sideways looks, and I got a lot of incoming fire from various places. But one of the things that I determined to do throughout it is to make sure that as I advocate for these things, that I'm transparent, that I work with people, that I listen to what they have to say, and that I try as hard as I can to make sure that what I do is not some mystery, right? I'm being very upfront about it, and I'm being very forthright in the sense of why I think it's good for us and why I think it's good for everyone, why I think it is essential for patients. And I had to just say thank you. I see a lot of faces in the crowd of people over the last year who've helped me a lot, who helped me through some of these difficult times, have partnered with us. I think we're really close to seeing success here. And so part of that success is our efforts, but it's also equally a lot of people in the crowd who have sort of joined along with us to help it make it a reality. So thank you, and thank you to Paul and AAKP who've been amazing partners in this. And with that, I'll stop.
So I think Paul mentioned I was a healthcare professional, and since sitting is equated with the new smoking, I just want everybody to stand up for 1 second. Shake your feet out. Give it that sigh. Take a deep breath. Now you're all ready to hear me, right?
They're fun hill minutes.
Yeah, I can tell you some stories about how my second day of work, I was on the Hill with Paul. And it was the first time I was going up on the Hill, and after we walked out, I said, "How did I do? That's the first time I ever did this." And he said, "Really?" I was like, "Uh-oh." But it's all good, and I have to tell you that I really do enjoy working with Paul, and we're going to shift a little because you might say to me, what's the Gerontological Society of America? How do I even say Gerontological Society of America? And why are we here? And why are we working together on an issue? And what I hope at the end is that you realize, especially for me, when we're talking to our boards about why we do the work that we do, that they understand that and recognize the value. So just a little bit about the Gerontological Society. We are a professional membership association. Our members are multidisciplinary, and when I say that, I mean it's beyond just healthcare. So we have members who are studying biology of aging. So they're studying the mice and the worms to see how we translate what we learn about them in aging to how we can translate that for humans, for increasing our health span and increasing our lifespan, but also increasing our health span. We have members who are economists, demographers, sociologists, psychologists, physicians, pharmacists, nurses, social workers. So they practice in a variety of settings, in a variety of areas. They conduct research, but the common thread is aging, right? And when I talk about aging, it's across the life course. So we're really concerned about what happens to someone when they're 4, 5, and 6, and 18, 19, and 20, because it's going to impact them when they're 50, 60, 70. And now we talk about the 85 plus population as the largest growing population. And we can do that because of the research that we've done and the science that we've been able to implement. The fun job that I get is to try to explain some of the work that they do. But also, how do we translate this evidence into research, into policy, and into practice? So that's just a little bit about GSA. I serve on the steering committee with Paul of the Protecting Access to Pain Relief Coalition. And just a little bit about the coalition. We formed in 2015. The coalition probably formed about 2 weeks before I started working for GSA. And the job is to advocate for safe and effective use of over-the-counter pain medication. And I know why that's important for all, we all know why that's important for all of us, but the world doesn't always recognize that. So our job is to advocate for the policy support and to educate patients about the importance of responsible use of acetaminophen. We have more than 20 organizations that are members, diverse backgrounds, representing patient advocates, representing professional membership associations, women's health, chronic pain management. We all come together around this one issue. And essentially what happened was in 2014, the FDA signaled that they were going to reduce access or halt access to over-the-counter acetaminophen greater than 500 milligram, greater than 325 milligram strength. So essentially an extra strength Tylenol that you could get in your pharmacy or get at the grocery store. And when I talk about the rationale, it made sense at the time. There were some consequences of people having unintentional overdoses. People took too much. As a pharmacist, I have often had to counsel patients that over-the-counter medications are medications. So you have to think about that. I also have to counsel people that if one is good, that doesn't always mean two is better. But yet some people, you have to work with them. And honestly, people didn't realize that acetaminophen, Tylenol, and AAKP were all the same drug, yet we had labels that would be written that way. You have cough and cold products that contain acetaminophen. You have different versions of acetaminophen products, and there was some confusion, and we needed to have some education of the public about how to use acetaminophen appropriately. So our position was, well, wait a minute. We don't want to see anybody die from acetaminophen overdose either. However, there's a group of people that there are some unintended consequences with respect to acetaminophen, not being able to have access to acetaminophen. So from my perspective, an older adult, we don't want them to be taking over-the-counter nonsteroidals because of the gastrointestinal issues, plus there's a black box warning for cardiovascular disease. For kidney patients, and as Paul always represents, is that there's a huge education issue because we don't want people taking nonsteroidals because that's going to lead to potential rejection of your transplant. So we went out and said, okay, it's time to organize, and it's time to go out and educate people because as much as this was very well intentioned, we want to make sure that you realize the unintended consequences. So we organized in the coalition and came up with a strategy of, who are we going to go speak with, why are we going to go speak with them, and what do we want them to do. I'm happy to say, so we met with members of Congress and their staff. They got the message, they got the idea, they understood it when we talked about it. There were members of appropriations and oversight committees. There were members of the Kidney Caucus. There are members who have interest in aging that we regularly work with who were very receptive to our message. We met with folks in the administration. And over the last 3 to 4 years, now when we come in to visit, they're like, okay, yeah, we get this point, what's the next piece? And so it's really great because now when we go in and start to talk a little bit more about issues, and I could get to one piece that's just recently happened, you'll see how this starts to really, these coalitions coming from a variety of different backgrounds really starts to move the needle. With the FDA, we were talking with them for a while and hoping that we would be able to get some funding to actually, how do you teach people through gaming models to change their behavior? And it was a pretty interesting, we got almost to the finish line on it, and then the money got pulled back. But we got the FDA educated. That was the important piece. And they also realized that when we first walked in, we were a group of 15 people at the table, and they're like, oh, what's this all about? Like you weren't sure like where everybody was. And when they realized that we kept coming back and saying, no, we really want to work with you on this. We really want to work with you on this. And their first response was, well, our only option is to take the drug off the market. We don't have an education opportunity. We're like, well, there's education opportunities. What happened when we had our grant rejected was they said, well, we think that education has worked. The education that we've done over the past few years has worked. So we're like, okay, great. We didn't get the grant that we wanted to see how we could change people's behavior, but we did get them to say that education does work. And I hope that even just when you think about when you go home, just some things that have happened, and maybe you don't realize that the concerted effort, but just how you see education now around AAKP is acetaminophen. Acetaminophen is Tylenol. Tylenol is in other products. There's different ways that the products are labeled, hopefully to bring attention to you as a consumer, to make sure that you're not unintentionally taking more acetaminophen than you should be. We conducted Hill briefings. We worked with the FDA. We then started to evolve, right? So, we sort of start to see that we're able to get our message across about acetaminophen and education. So now we're in the middle of an opioid crisis, and you're going to remove access to one of the medications that we would recommend for somebody. And you say, well, wait a minute, opioids are really strong, and acetaminophen and non-steroidals, they're over the counter, they're not as strong. Well, some research has come out, studies have come out in JAMA. There was a study that showed that acetaminophen and nonsteroidals were just as effective in a knee replacement as starting somebody on an opioid. And what we do know is that if you can prevent somebody from being put on the opioid to begin with, or you can get them off within the first 7 days, you'll be more successful that they won't be on that medication 90 days later. And if they're on it 90 days later, it's harder for them to come off of it. And that's where we start to see this opioid crisis really start to cause a challenge for people. So there is evidence out there that shows that. So, okay, now there's an interagency task force on pain management. We want to make sure that they know about that, because here's yet another part of HHS that's going to say, well, this is why it's important to make sure that we keep acetaminophen access available to patients. The other piece is, and I know this just from family members and anybody else, so the 325 milligram dose of acetaminophen is going to stay on the market. If it stays on the market, what's somebody going to do if they can't get access to a 500 milligram dose? They're going to take 2 tablets. Now they're taking 650. So your whole point is moot, right? Of how you take the drug off the market. And most recently, one of the pieces, and just to show you how the coalition has evolved and how we think it's important across taking that life course approach. There has been research done, and it has been widely known that there's dosage for children, for pediatrics, 6 months to 2 years. But any of you parents who have recently bought a product and looked what it says on the label for acetaminophen, if you went to give it to somebody between 6 months and 2 years? What's that?
It doesn't have there's no information there.
Right.
It's just have it for like 2, 3, 5.
Yeah.
But that top one, it's just like
it says call your healthcare provider. When does your 6 month to 2 year old child ever need their acetaminophen at 3 a.m? And who is available at 3 a.m. to give you that information? Or as you're trying to take care of a sick child, like you want to get on the phone and say, what do I do? So we were recently able to get some report language in the House to ask for a report as to, we know this data exists, what's your next step? or can you give us a report telling us where you're going to be? So we continue to build on our successes. So you start with that one issue, and we can keep building on that to be sure that we can make sure that we're providing safe and effective use of medications. So one of the things when Paul and Diana asked me to come speak, said, talk about the importance of these coalitions, and I think about that often, particularly when I think about the Paper Coalition, because we're not normally people who are sitting in the same rooms together otherwise. And I think about how I'm a department of 1.3 people. Most policy departments, they're either like huge policy shops or they're 1.3 people. And when you can rely on other colleagues, right, we have a collective voice. And I think that's why when FDA and when CMS and when HHS and the White House have seen us, they see us come from a variety of backgrounds. And what we bring to the table is that variety of backgrounds. We have different contacts, but we have different ways to be able to approach. Usually Paul will set me up in a Hill visit. Paul will start to talk all the legislative language, and then he'll say, now Trisha's going to tell you about what you need to think about for your grandmother, right? Because when we're talking to the Hill staffer, we want to make sure that we bring it home to them. I think the richness and diversity of this coalition has really been helpful and has made us successful. And what's really great is I'm able to tell our members that we are taking their research and we are showing how this is important and applicable in policy and in practice. And I know that all of us, when we're sitting there, we're talking about how we represent our members. And so what's even better is when we're putting messages out that our members continue to tell us, way to go, let's keep going, let's make sure that we get the right message out there. So if you want to learn more, I put our web address up there for the coalition, and happy to take questions when we finish.
Thank you. Thank you for having me. I'm really excited because we are, as the Partnership to Improve Patient Care, and my name is Sarah Van Gertruden, by the way. I have like the really long name. But I feel like we've sort of been waiting 10 years for PCORI reauthorization. It's something I feel like we've been preparing for and getting ready for, and now it's finally here. So I'm excited to talk to you a little bit about that, and to talk to you a little bit about, because for some people, they look at me and they go, how in the world is PCORI controversial? So I am going to dive in a little bit into some of the issues that could potentially make it controversial, but we hope not. So just a little bit about who we are, the Partnership to Improve Patient Care. We are a coalition that was originally created by Tony Coelho. Tony is a disability rights advocate, former congressman, wrote the Americans with Disabilities Act. Having epilepsy himself, Tony really comes to these issues from a personal standpoint. He remembers when he was first diagnosed in his 20s and you had to still mark on a job application, do you have this disease? And he had to check yes to epilepsy. And it really created some problems for him in getting a job. He didn't have a driver's license. And because of that, as he evolved into public policy and was a staffer on the Hill and then became a member himself, it became a huge priority. And so as a coalition, he strongly supported PCORI's creation and brought PIPC together to support the Senate version, which I'll talk a little bit about. So overcoming the politics, really, so the interesting thing about PCORI is that there were politics on both far right and far left that influenced its creation. On the right, you had certain Republicans that said that there was little to stop the federal government from using comparative effectiveness research results to average which medications or treatments would achieve similar results for less cost. And when that happens, according to particularly Senator Roberts, it won't be long before Medicare starts rationing care. So this was the perspective that was largely brought by the far right. But then you had on the far left a different perspective. The far left wanted PCORI to not be independent, to instead be part of government. They wanted it to allow for cost comparisons, and they wanted cost effectiveness data to then be translated into coverage decisions by Medicare. What ultimately happened is, thankfully, rational minds in the middle came together and tried to make PCORI a patient-centered entity. That's how it became named the Patient-Centered Outcomes Research Institute. Max Baucus and Senator Conrad introduced what was initially the Comparative Effectiveness Research Act in 2008, which evolved into the Patient-Centered Outcomes Research Act of 2009. And it was passed as part of the Affordable Care Act as a compromise between the right and the left. So while the Affordable Care Act is known to have been partisan, this particular piece of it was actually bipartisan. So there are some key patient protections that are included in PCORI's statute. First of all, it defines comparative effectiveness research as comparative clinical effectiveness research, with an emphasis on looking at the outcomes that matter to patients and people with disabilities when they're actually making decisions. It precluded PCORI's research from being the sole source of a Medicare coverage decision. So instead of it being used to say, okay, A works better than B, so we're only going to cover A, despite the fact that B might work better for some people. That didn't happen. There's a particular protection in the statute for that. It banned the use of what's called the Quality Adjusted Life Year, which I'm going to talk a little bit about later as well. This is the piece that could potentially make PCORI's reauthorization controversial. And it made PCORI, as I mentioned, an independent institute with seats on the board for patients and consumers. So as Tony often says, not only having a voice, but a vote, which is a very important thing. And it specifically says patient needs, outcomes and preferences, and subpopulations are to be studied. Again, getting to this, instead of saying A works better than B, really trying to understand why A might work better for some people and why B might work better for other people. So really recognizing that patient populations are not homogeneous. And then there's support for patient and consumer representatives and authority for advisory panels. So since PCORI was created in 2010, part of, on the Hill, we often get criticized that there haven't been a lot of folks out there advocating for PCORI over the last 10 years. And I can tell you that this has been the source of great debate, too, over the last 10 years, because the goal was to sort of keep PCORI away from the repeal and replace debate. There's a lot of really great work. There are 18 studies in the kidney field being done over at PCORI, all of which are intended to help people make good decisions. But we're, now I think we're at a point where we understand that, it's up for reauthorization and we're out there ready to tell the good story. So there are lots of ways in which PCORI supports improved health decisions. Again, getting down to subpopulation data. PCORI-funded research is perceived as reliable. Its evidence synthesis initiative and dissemination strategies ensure that patients and providers have access to information on all treatment options and their value. One of the important things in PCORI, and I think probably something that will be a larger focus hopefully over the next 10 years, assuming it gets reauthorized, is going to be how do you translate all of this great information that's coming out of PCORI then into decision aids and shared decision-making tools so that it's actually usable at the point of care. And PCORI, because of those patient protections I mentioned earlier, does not support a one-size healthcare system. It really is looking at what matters to patients. And because patients are engaged at every step of the PCORI research process, it really does allow for the outcomes to be measured to be reflective of what patients care about. So as you may know, PCORI expires in September of 2019. At this point, there are 4 members on the Senate side, 2 Republicans and 2 Democrats actively working to draft a PCORI reauthorization statute or bill. It's going to be bipartisan. We hope to see a draft soon with a formal introduction sometime in July. It's going to be probably part of the extenders package, which will include a whole host of other issues like the Children's Health Insurance Program and the Disproportionate Share Hospital Program. So it won't be probably passed on its own, it'll be passed as part of a package. On the House side, Congresswoman DeGette from Colorado has introduced what's called a straight reauthorization bill, so it just takes the existing statute and extends it for 10 years. But But she's also looking to partner with others, particularly on the Republican side, to introduce a bipartisan bill. So when, coming into this year, it was largely recognized that there were a lot of people that wanted to support PCORI, both who were part of PIPSI and who were not. And so we decided that it was probably wise to create a broader coalition effort called Friends of PCORI Reauthorization. Tony's been doing this with former Congressman Dr. Phil Gingrey, who is from Georgia. He was the founder of the DOT Caucus, and he's fascinating. I was at an event, I guess it was about a year ago at the Bipartisan Policy Center, where he was on the stage and he said, when PCORI was being debated, I did not support it. He said, I really thought that it was going to, that would be used to come between the doctor and the patient, that somebody from on high was going to say, this is what you should do, instead of allowing me as a doctor to make those decisions. And then he looked at Senator Conrad, who was on the stage with him, and he said, and you know what? I was wrong. PCORI, the patient protections that are included in PCORI statute have been great. They've really allowed the organization to do clinical effectiveness research that helps people make decisions as opposed to dictating those decisions. And it was because of that event that then Tony picked up the phone and called him and said, we need to get together on this then and make it bipartisan. So that's what we're trying to do. Would welcome you to, become part of Friends of PCORI Reauth if you're not already. We're really excited that so many organizations, we had a letter signed by over 170 actually organizations over to the House and Senate to support PCORI Reauth. But we're going to have to really focus on, things like there's a lot of consideration on the Hill for it being a short-term reauthorization as opposed to a 10-year reauthorization. But I think we're going to hopefully work through those issues. It may not be 10 years, but hopefully it'll be something close. So as I mentioned earlier, inside of the PCORI statute, there is a ban on the use of a quality-adjusted life year. The quality-adjusted life year is a really interesting, is a very interesting metric. It basically what it does is to measure what's better based on this quality adjusted life year. It looks at things like life extension, and it looks at quality of life based on surveys. It's typically used by researchers to do cost effectiveness analyses, also known as value assessments. And then, and for stakeholders who use QALYs, it's kind of looked at as a single metric, right? So an insurer might look at a quality adjusted life year cost effectiveness analyses and say, okay, well, A works better than B, or A is more cost effective than B based on this study, and that is going to then inform where they place things on their in their coverage and benefit design. But the good news is that QALYs have historically been rejected by policymakers. So both in the Affordable Care Act as part of the PCORI statute, PCORI does not use the quality adjusted life year. Medicare is not allowed to use the quality adjusted life year to determine its coverage decisions. And even as far back as in 1992, the Medicaid program, it was the state of Oregon had submitted a waiver to say we're going to use a quality adjusted life year metric to determine our prioritized list of services. The HHS secretary, and keep in mind 1992 is right after the Americans with Disabilities Act passed in 1990, right? The HHS secretary said, no, you can't do that. That would be discriminatory. And so this is just an excerpt from a New York Times opinion piece that the then secretary submitted to explain why he sent the Oregon waiver back, because the implications would be discriminatory, that certain services would be deemed not cost effective and therefore not covered, that typically were for people with disabilities. And so just to explain how that works, if you have a disability, say you're the gentleman in the wheelchair, your maximum potential for health, and I'm going to put that in quotes, might be a 0.7, right? You're always going to be in a wheelchair. So if you get sick, maybe that brings you down to a 0.2. But the incremental improvement in health that you can achieve on a particular treatment might bring you just from that 0.2 to the 0.7, so that's 0.5. If you are somebody who is sick at a 0.2, but you can get back to a 1, right? So you don't have a long-term disability. It's something that you can fully recover from. Your incremental improvement is going to look larger. It looks more like a 0.8, right? So what happens with this metric is that there's inherent discrimination against people who might be older, so they may have less years left to live, or who may have more disease progression, so that they're never going to get to the 1, but they will have some health improvement. So the QALY is a means of measuring health quality. It looks at burden of the disease and the treatment efficacy in mitigating it. So as I mentioned, 1 QALY is the perfect health, 0 is death, and somewhere in between is a disabled or sick life. So it's very limited when it's used in a cost-effectiveness analysis. It's been acknowledged by experts to discriminate by placing a lower value on their lives. It devalues the full range of benefits and costs that matter to patients through simplified disability weight systems, and ignores important variability in patients' individual needs and preferences because it's developed using population averages. So another challenge with the QALY model is just how they get to those. So there are surveys that they will do, and I'll just to summarize this, what happens when you're trying to develop this quality adjusted life. Your metric is somebody will go out and they'll survey the general population. They'll say, would you rather be in this state or that state? And to somebody who has never experienced a disability, they might say, oh, I would never want to have that. I would never want to be blind. I would never want to have HIV, I would never want to have. And so to them, their visceral reaction might be that would be a horrible quality of life. Whereas somebody who actually lives in that state would say, well, I mean, I think my life has value. I think I'm living a high quality of life. And so it really does skew the results that we do, that these are calculated through these sort of general population surveys. So Peter Singer is sort of a firebrand in the disability community. He is a bioethicist that essentially believes that a treatment that extends the lives of people without disabilities provides twice the value of one that extends for a similar period the lives of quadriplegics. This is the example that he uses as part of this longer document. But it sort of supports the idea that we should be rationing care in this country, and I think a lot of folks in the disability and patient communities would disagree. So underlying all of this, I mean, from PIPSI's perspective, is that different people respond differently to the same drugs, right? And that's why PCORI was created the way it was created. We wanted to make sure that PCORI captured this idea that it's not just that A works better than B. It's A works better for these people and here's why, and B works better for these people and here's why, to help people make better decisions. And the other problem oftentimes with basing coverage and payment and access on these types of research projects is that for many conditions, disparities are reflected in clinical knowledge, but not yet in the research literature. It often takes an extended period of time to really understand what's happening in the real world with different various treatments. And we need to make sure that people have access to them so that we can learn from that real world experience. But in the meantime, we also need to give clinicians the power and the ability to make decisions based on what they're seeing in their everyday practice, because they probably know more than the research knows. So why do QALYs matter? I think the big challenge, and we've done, the Exenda in particular has done some work looking at what would happen if we used a QALY-based assessment to determine access to treatments in Medicare Part B, Medicaid, and what they have found is that there would be some significant challenges for patients who would then have to switch medications or would find their medication to not be covered. So there's a group, and some of you may have heard of, called the Institute for Clinical Economic Review that does these types of value assessments, which private insurers often use. But we have been very actively trying to make sure that those types of value assessments are not used in public programs, that instead we sort of follow the PCORI model. The other thing is that in the VA is already referencing these QALY-based value assessments that are produced by ICER. And we are finding that when you look at what ICER has determined to be of low to intermediate value, It is translating into what is covered on the national formulary, on the VA's national formulary. So there is some room to be worried. So PCORI's patient protections ensure its work is used to help you make better decisions and not limit your choices. And we want to make sure that through reauthorization, those protections continue and remain in place. So what can you do as advocates? PCORI's number one constituency is patients. The Hill wants to hear that patients care about the work that PCORI is doing and that patients care about those patient protections that are in its statute. If patients see PCORI as valuable, then the Hill is going to see the PCORI as valuable. So it's up to us to connect those dots. I would encourage you to go on PCORI's website. They have a whole section of the website dedicated to the work that they're doing in for kidney patients. Please follow and engage with Friends of PCORI Reauthorization. And this is our website. So we would urge you to go there. We have great advocacy materials. And you don't have to just do meetings when you're here in DC. I often tell folks that engage with us, meet with your members when they're home. You'll probably get more time out of them when they're in their district office and from their district staff where they're a little bit less busy than they are here. So if there's anything that I can do to support your advocacy, please let me know. And thank you for being here. I'm excited to have been able to present.
So, I apologize for the length of the panel, but we wanted to make certain a lot of content got out because, again, we're filming. We can segment this. What I'd like to do is ask our guests to come up now, and we'll do some questions and answers, and then I'll also highlight what we're actually going to be doing tomorrow, non-film environment, where we actually get into some of these issues. A couple of things that I'd like to mention right off the top. First, Sandeep needed to leave. He's got a very active schedule at HHS. And the other thing I'd like to recognize is that Jennifer Erickson is actually meeting at a house that is painted white down the street. Just to highlight the point that, again, for those folks who care about innovation in kidney disease, it is about the policy, about getting more choices and getting the questions and the problems solved. The fact that you have somebody that was a senior official in the White House for President Obama is down the street meeting with the successive administration is a sign that we're trying to get things done. And that's really the spirit that we're trying to approach things with. So first, right off the top, any questions for our panelists before I pose the first one? Here you go. Here's the question. So some of you have put up information about how to be effective in terms of engaging. We're filming this. We'll be taking this and segmenting out the film to send out to activists and patient advocates and caregivers and others across the country. But for some of these issues, obviously on the reauthorization issue of PCORI, has a large coalition around it. It's in the Congress. For other coalitions like Paper Coalition, you have a lot of stakeholders and it's focused on executive branch action. And then on our other two issues here, with Chris, in particular, the issue is before CMS. So each of those things involve different strategies. And for those who are listening and for those who are watching, can you each, again, hit what are the key things that patients and patient advocates and advocacy allies could do to move the needle in the direction of trying to create more choice from your perspective?
For PCORI reauthorization in particular, I think telling a positive story about the need for improved decision-making at the point of care, your support for research, and if you have familiarity with any of the individual studies that are being done by PCORI, that you are able to articulate to policymakers, I think that's very important. We like to hear those personal stories that I'm aware of this project or I'm engaged in this project. And this is what I think this project will mean for me. That's very important. And I think that you could be meeting with them either here in DC or in the district. Either one is perfectly fine. But I think hitting the highlights of it needs to be a long-term reauthorization, keep those patient protections in the statute, and make sure that it gets done in a timely way.
Kidney disease creates a backdrop for everyone to be able to do more than we ever could before. And so I would suggest to all of you that are involved in advocacy for whatever issue is to try to tie whatever you're trying to get accomplished to this overall mission, this overall vision, which I think has been very well articulated by the administration. And so whether it is, choice, whether it's, comparing the effectiveness of various products or whatever kind of policies on drugs or whatever, I think it's important to set the backdrop of what you're trying to do, because I do think that this is a really unusual situation, again, in all the long-term government affairs work that I've done in a lot of different therapeutic areas. I think the kidney community has a very unique opportunity to try to explain whatever you're advocating for in this broader context. And I guess just one other point is that I think on a lot of these issues it's really important to understand that all the stakeholders involved in the decision making need to be the touchstones. And so you've got Congress. I think you need to go to your individual legislators, or the key members on authorizing committees, as well as any of the political staff or even career staff within the federal agencies, because I think everyone has a role to play. Certainly Congress has the power to assert, how they believe that laws that they pass need to be interpreted by agencies. And agencies have, the responsibility of being, stewards of the federal government and government services servants to carry out those laws. And so I just encourage you to not exclusively look at the executive branch or the legislative branch, but really look across the board with all stakeholders.
So I would agree with that statement. I think one of the things that was really successful for us was the process of engaging with both the administration and with members of Congress. But that being said, with members of the administration, what's really been helpful for us are telling stories, being able to tell the story. So when we hear from our members about their stories and we can recount those. Also, what's really helpful for us is it can't be underestimated around social media. And what we often find is that we are able to go in collectively and talk about our strength from a social media perspective with the administration and with members of Congress, and they listen to that. And so when we put a message out and we know that there are over 60,000 collectively people that have the opportunity to retweet what we've said, that's really powerful and really helpful. And so what I would say is really important is as you're following, and for any organization that you're working with, as you're following what might be out there on social media, being able to help amplify that is really important.
Chris?
Yeah, I mean, what comes to mind, to me at least, is this is, like Sarah was saying, this is a unique opportunity, and one of the reasons why is because when you do advocacy, usually, you can have really good arguments and lots of good data, but when you go and sit down with a policymaker or staff, the one thing they always ask you is, well, why do you want me to do it right now, right? Is there a reason for this, right? Is there you need to have like that action forcing event, say, oh, there's this thing that's going to happen, and if we don't do X by X, then there's going to be a whatever, right? And that's why right now it's really important, right? We have the Secretary of HHS spending a lot of time and effort focusing on this space. And that is, sort of resounding through the department, it's resounding through the agency. You're hearing it on the Hill. But not everywhere thank you. But not but not everywhere on the Hill. And so when you, when I go and I visit with staff, for instance, I always say, are you aware of what the secretary is saying? This because they don't know. I mean, a lot of staff, they don't know anything. And they know a little bit, or maybe a little, a lot. But if you tie what you're talking about to what is happening and say, listen, this is a momentous time. The Secretary of HHS is doing this for all these reasons. And this is why you need to focus on it now. Like not next year, like right now. And because because I know I say this to like people at Baxter is because they're like, yeah, this is great. All these great things are going to happen. I say this administration could be gone in like 18 months, right? And then we'll have a new administration, maybe. And that means anything that they do, like this can be a whole new crew that's implemented. Right? And so if you guys are thinking about your advocacy, you need to think about it in terms of timing. Like now is the time. Go in there and make your case now and do it and get as much done as you can now so that when we get into the future, if there is a new administration, which obviously we don't know, but if there is, then all that stuff is in place. And then you can work on it and build it and you can expand it. So I would definitely tie what you're saying to sort of the overall, environment and use that as your catalyst to demand change.
If I could pick up on this. So in the case of PCORI, it's 10 years ago the authorization went through. So you can imagine how many different congressional cycles and elections have gone through, how many turnovers in the House and Senate. And each time you do that, one of the estimates that's out there is you lose 30% of your top talent in every congressional office. So from an advocacy perspective, it's going back and building up that base of knowledge again and the history. Now it's 10 years later. The point that Krister's raising is critically important, and it's one of the reasons why at AAKP we focus on presidential transition teams. And we always have. I've served on 5 because the continuity of knowledge, so you have the political food fight happens, that's American democracy. But what happens afterwards is the transition and the passing of the torch between 2 administrations. And apart from some of the headlines and the stories about people stealing a W off of a computer or people, leaving nasty notes for their successor, in most cases, it's a fairly smooth and very orderly process. It's very intense, and briefing documents are created. It's one of the principal reasons why we have asked Jennifer Erickson to be part of our dialogues consistently, because her first appearance in the kidney community came as a White House official in front of the Kidney Health Initiative. And even before that, Richard Knight and I had an opportunity to sit down with the entire White House Science and Technology team and the Council of Economic Advisors, because she understood these are issues that are happening. It was 2015, 2016. She didn't know what was going on, but she cared about the issue. So transitioning the issue to the next team actually matters. But this is a key point. You have 18 months to produce results. It's an even shorter amount of time because during an election year, everything gets viewed through a different lens. So the ability to keep a consensus together becomes much more difficult. But again, all of your insights are highly valuable, and the fact that everyone today has been consistent on the fact that there's a rare window of time actually matters. And it's one of the reasons why we're in the middle of a voter registration drive. It's the largest that's ever happened in the kidney community for kidney patients. We'll be driving that all the way through 2020. We have new online tools for that. And we're also intensely dedicated to educating patients and also the decision makers on these issues. Any other questions in the room? We'll try to wrap today on time, but we have room for anything else. If not, an applause for our guests, please. Thank you. Brief note on tomorrow morning. So tomorrow morning there's breakfast from 8:30 to 9:30, and then from 9:30 to 11:30 we're going to do 2 breakout sessions. Be a more limited number of people, it usually is. We don't have cameras, it's not the first day, but this is a roll up the sleeves type of day where the first round in the first hour we'll take a look at more of the details of issues in front of the executive branch, CMS, FDA, CMMI, and we'll take a look at where there are overlaps on policy agendas with different organizations, especially advocacy organizations. And then in the second hour, we will get into the brass tacks of the specific tools for advocacy that each of our respective organizations can bring to bear. Social media, direct mail, video, television access to national news. I thought it was great that CareDx had up their television interviews with CNBC. We have direct access to Fox Business News and Fox News. that's where we're actually going to start laying out what are the tools we have available. It doesn't mean everyone has to do the same thing at the same time, but it does mean that we have organizations like CareDx, who's been very generous in jumpstarting new national coalitions and platforms, that everyone in the room is aware of them, and everyone in the room is making access. One of the best organizing tactics that has ever been in politics came from the labor movement, which is if you have 10 labor unions, each of the 10 members need to belong to all 10. Because at the end of the day, it's almost a luxury to be able to sit as a physician or to sit as a pharmaceutical executive or a patient or a researcher and throw spitballs back and forth all day at each other. What luxury. When you're a patient and your life depends on it, you need consistency and you need coordination, you need strategy in order to have the sense of urgency to get something done. Otherwise, we're just another voice in the process and another problem. But we're intensely dedicated about trying to lay these things out and get some results done before the end of this year. So thank you very much for your attention today. Thanks for coming. Bye-bye.